Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about antifungal medications. Antifungal medications for dermatophyte or tinea infections include topical and systemic agents. The main classes are Allylamines, example Terbinafine, Azoles, example Clotrimazole, Onychomycosis, Itraconazole, Fluconazole, and Griseofulvin. Topical agents are preferred for localized skin infections, while oral agents are indicated for extensive refractory or hair nail involvement. Tinea pedis or athlete's foot. First-line therapy is topical antifungals such as Terbinafine, butanafine or azoles, example Clotrimazole and Onychomycosis, applied once or twice daily for 2 to 4 weeks, with a longer duration up to 6 weeks for mucosal type or chronic infections. Oral Terbinafine or Itraconazole may be considered for extensive refractory or hyperkeratotic cases. Here we can see Tinea pedis or athlete's foot. Tinea cruris or jog itch. In Tinea cruris, topical antifungals like Terbinafine, butanafine, azoles are effective, applied once or twice daily for 2 to 4 weeks. Oral therapy like Terbinafine or Itraconazole is reserved for extensive or recalcitrant cases. Here we can see Tinea cruris or jog itch. Tinea corporis or ringworm of the body. Topical antifungals like Terbinafine, butanafine, azoles are first line and applied for 2 to 4 weeks, and oral therapy like Terbinafine or Itraconazole is indicated for extensive disease, immunocompromised patients, or failed topical therapy. And we can see Tinea corporis or ringworm of the body. Onychomycosis or Tinea Tinea oral therapy is required for most cases. Terbinafine 250 mg daily for 6 weeks for fingernails or 12 weeks for toenails is first line, with Itraconazole as an alternative. Topical agents like cyclopirox and Onychomycosis and topical may be considered for mild superficial cases or when oral therapy is contraindicated but efficacy is lower. Note: Griseofulvin is less effective for onychomycosis and generally not recommended. Here we can see onychomycosis or tinea unguium or fungal nail infection. Tinea capitis or scalp ringworm. The recommended treatment for tinea capitis is systemic antifungal therapy, as topical agents are ineffective due to poor penetration of the hair shaft. The choice of oral agent should be guided by the causative organism, which ideally is identified by fungal culture or molecular methods. For Trichophyton species, especially Trichophyton tonsurans, oral terbinafine is preferred due to superior efficacy and shorter treatment duration, typically 2 to 4 weeks. For Microsporum species such as Microsporum canis, more prevalent globally, oral Griseofulvin remains the agent of choice with treatment duration of 6 to 8 weeks, as it demonstrates higher cure rates than Terbinafine for these organisms. If Griseofulvin is unavailable, alternatives include Fluconazole or Itraconazole, which have similar efficacy to Griseofulvin for Trichophyton infections and are reasonable substitutes for Microsporum infections, though evidence for optimal dosing and duration is less robust. Dosing regimens are as follows: Terbinafine, weight-based dosing for children, typically 5 to 10 mg per kilogram per day. Maximum dose is 250 mg per day for 2 to 4 weeks. Griseofulvin 20 to 25 mg per kilogram per day, which is a micro-size formulation for 6 to 8 weeks, and Fluconazole 6 mg per kilogram per day for 3 to 6 weeks, and Itraconazole 5 mg per kilogram per day for 2 to 6 weeks. Adjunctive therapy with antifungal shampoos, example selenium sulfide or Ketoconazole 2 to 3 times weekly, is recommended to reduce transmission and environmental contamination. In severe inflammatory cases or carrion, a short course of oral corticosteroids may be considered, though evidence is limited and use remains controversial. Regular monitoring for adverse effects, particularly liver function, is advised during prolonged systemic therapy. Early diagnosis Species identification and patient caregiver education are essential to optimize outcomes and prevent chronic infection or permanent alopecia. In summary, oral terbinafine is first line for trichophyton infections, Griseofulvin for microsporum infections with Fluconazole or Itraconazole is alternative when needed. Adjunctive antifungal shampoos and in select cases corticosteroids may be used to support therapy and reduce transmission. Here we can see Tinea capitis or scalp ringworm. Here we can see their carrion formation. General principles. Diagnosis should be confirmed by direct microscopy with potassium hydroxide preparation or culture, especially for onychomycosis and tinea capitis. Hygiene measures and avoidance of combination antifungal corticosteroid preparations are recommended to prevent resistance and optimize outcomes. Rising resistance, particularly to terbinafine, is an emerging concern and may necessitate alternative therapies. In summary, topical antifungals are effective for most superficial tinea infections, while oral agents are required for nail, scalp, and extensive disease. Terbinafine and Itraconazole are the mainstay of oral therapy, with Griseofulvin reserved for microsporum infections. Okay, this was a short explanation about fungal infections and treatment of fungal infections or antifungal medications. Thank you for your attention.